I will be the first one to be fast and not to lose time. So I would like to call on the stage Professor Mathew Wilson, that is the Director of Research at Aspetar. And he has a huge experience in athlete heart and mechanism of sudden cardiac death. He has a huge experience with thousands of screening for athletes, and he published extensively about the baseline cardiological data for different ethnicity, and especially about the GCC athletes. So looking forward to hear his talk that is about cardiac peculiarities on GCC athletes. Thank you.
Good morning, everybody. Can we just do a favor and close the doors, please? Just either side, can we close the doors? Thank you. My presentation, please. So it's a great honor to speak here today. And just to put this into context, this is about ECG peculiarities. And peculiarities is a strange word because it means something that is not normal or slightly bizarre or something funny looking and you're not quite sure what that means. But just to say that I have no disclosures to make. And this is the reason why Aspetar has an athlete screening department. Just take a look at these pictures. These are young individuals who have had a cardiac event. These people have died. These are apparently young and fit, healthy individuals. In the vast majority, they are asymptomatic, they have no prior symptoms, and these individuals, unfortunately, have passed away in or after the sport of play. And I'm not going to dwell too much upon the etiology and the epidemiology of sudden cardiac death because my colleagues after me will present why we do it, but it's a rare occurrence. We know it occurs in young individuals. We know that males have a high predominance of sudden cardiac death compared to females. But the most important point, and the point that I want you to take away from today, is that 90% of deaths occur either during or within 6 hours after sport. So it's called exercise-related sudden death. It's slightly more complex, though, than just saying that you have a heart attack. There is a number of conditions that cause an arrest. It could be due to a cardiomyopathy, it could be due to an electrical condition, it could be due to an acquired condition, such as premature coronary artery disease. But in the vast majority of cases, there is an etiology and there is a mechanism causing these fatal arrhythmias to occur. But the problem that we face and you face in this room is that athletes are an abnormal group of individuals. You may have a little 8-year-old ballet dancer still doing 18 hours of exercise a week, or you may have a 7'6" black African basketball player, again doing 15 hours of exercise a week. And the physiology of the different sporting demands requires that athletes have to have a big heart to pump a large amount of blood to achieve a good VO2 max, irrespective of training history, shall we say. So we get a number of changes, both electrical and structural, in order to enhance our functional capacity. But are these innocent or are they harbingers of pathology? That's where we fit in. So what we have in Aspetar is we have a frontline screening service where we essentially do a personal family history, a physical examination, and a 12-lead ECG. And that's where I'm going to stop, because my other colleagues will take this further on. And the title of my presentation is ECG Peculiarities. Now, what I don't want you to take away is I'm not going to show lots and lots of ECGs in this presentation and bore you all with ECGs. But what I will say is that ECG picks up 90% of individuals with hypertrophic cardiomyopathy. And believe me when I say that this ECG on this screen is strikingly abnormal. So remember that. ECG picks up 90% of hypertrophic cardiomyopathy. It's also good at picking up arrhythmogenic right ventricular cardiomyopathy. About 80%, we can pick that up as well. So surely, ECG, if we have a tool that is able to identify ECG abnormalities and potentially cardiac pathology, we actually are able to apply that in our elite athlete population. Of course, it's the only way of identifying pre-excitation and ion channelopathy disease. There is no other way of identifying these cardiac pathology except from ECG. The problem that we face, and I go back to my original point, is that athletes are an abnormal group. So when you look at this ECG and you've got these funny squiggles in front of you, how do you put that into context? Well, the European Society of Cardiology came up with a traffic light system. Green, which are features that are common in athletes, and red, which are abnormal features you should lend suspicion towards cardiac pathology. The problem is, these red ones here, how do we actually know if there's any evidence, any scientific evidence that all of these are related to pathology? And one of the big negatives against screening is the number of false positives, which is the number of ECGs to present and you're not sure about it. It's a peculiar ECG. And there's an expensive downstream cascade of expensive tests like echocardiography and cardiac MRI and stress testing, Holter. All these things weigh on the mind of the athlete. So how can we actually be sure that what is normal and what is abnormal? But the problem with these guidelines is they're based upon consensus. They're not evidence-derived. And when the Italians applied it to their population, out of 32,000, they found 11%, or almost 12% had an abnormal ECG, but under 1% actually had confirmed pathology. So again, 10% had a false positive ECG and expensive follow-up tests. The other thing that we find, and we see this a lot in all of the athletes across the GCC, is a huge influx of international migration. You have athletes from Africa, the GCC, the Far East, the subcontinent, North America, Brazil, lots and lots of Brazilian footballers, all coming to play sport in the GCC. And let me tell you, you see a large array of wonderful different ECGs, and they're all normal, but the reason why they're different is because of the athlete's ethnicity, and we've published extensively on that. We also find that there's a large amount of different types of migration, even within the GCC and the Arab Games. We know that the 13 Arab nations, Maghreb, GCC, right the way across, competed at the 2012 London Olympics. So we took those European Society of Cardiology guidelines and we applied them to our athletes that we saw in Qatar. And the false positive rates of Arab versus Black African versus Caucasian, you can see that actually, unlike the Italians in their predominantly white population found 12% of abnormal ECGs, we found actually 30% of our Africans had an abnormal ECG. It's statistically impossible for all these athletes to have cardiac pathology. And therefore, I put it to you that the ECG guidelines that they're being put out for the public are erroneous and actually potentially dangerous. So we need some better refined criteria. So what we decided is we were going to have a look at things that were associated with pathology and things that were associated with physiology. And I'll have a look at T-wave inversion, just briefly here, and long QT. Now, this is a black athlete with hypertrophic cardiomyopathy, and the red points are bad things, and the yellow is sort of amber, like an amber traffic light, shall we say. But we also see these amber things in 23% of our African athletes. And again, I go back to my point. It's statistically impossible for 23% of our black African athletes to have pathology. So what is the true association between T-wave inversion and pathology? Well, this is the Aspetar experience, and you can see here that the blue bars are Arabic, the green bars are our Caucasian, and the red bars are our black African athletes. And you can see the different locations. We know that ethnicity plays a key role of where you see these T-wave inversions. So again, when you look at the ECG, you have to put it into context. We'll take a look at the long QT, which is the contraction and the repolarization of the heartbeat. Ba-boom, and it recharges. Ba-boom, and it recharges. Okay, and there's a duration period of that. In England, we took 2,000 athletes going to the Olympic Games, and we studied them, and we found that those athletes had a very, very prolonged QT. Okay, if they had paradoxical QT prolongation during exercise, or they had a genetic mutation, or they had this pathology in a first-degree relative, and history is key, that was suspicious of cardiac pathology. But anything under 500 milliseconds was not very sensitive, not very specified either. So we applied that to some criteria. Hang on, is it not working? So what we did is we got together a group of experts from around the world and we called it the Seattle Conference. And if you want to see these guidelines, go to the British Journal of Sports Medicine, and we produced 3 sets of criteria. Normal ECG findings in athletes, physiological adaptations, abnormal suggestive of electrical disease, and abnormal suggestive of cardiomyopathy. So if you have an athlete in front of you and you are unsure about how to interpret this ECG, you will find 3 sets of ECG criteria from there. But importantly, how did this new criteria perform? Well, we took our Arabic population, and against the old recommendations which I showed you, which showed a 19%, we were able to reduce the percentage of false positives to under 10%. In our whites, it went from 18 to 8, and our blacks, it went from 30 to 16. So getting better, but still not good enough. So we're sort of moving away from consensus and getting more towards evidence-derived criteria, but I still believe we can make this better. So we took some other findings on the abnormal category, and these are called atrial enlargement, right axis deviation, right ventricular hypertrophy, and we used our calculations to say, well, actually, how sensitive are these? Everyone says it's a red warning light, but actually, how red warning light are they? And we found that they're about half of our athletes that have an abnormal ECG have these features. But we compared them against our athletes and about 9,000 controls from a hospital in St. George's in London, and we found no structural abnormalities in any of the athletes presenting with those features. So should they not now be taken out of red and put into green? We think so. We also did the same for right ventricular hypertrophy. Again, we followed them up with a large number of athletes and controls. Again, long-term follow-up over a number of years, we didn't find any pathology. Again, moving from red to green. So we decided, actually, life is not black and white, it's sort of a bit gray. So you can take a photo of this, and this is going to be published soon, in the next couple of months, in 3 major cardiological journals. Hopefully, the European Society of Cardiology, the Journal of American College of Cardiology, BJSM, and Heart. And we decided that actually it is like a traffic light system. There are things here that are actually clearly abnormal. But also, athletes present with some pretty normal ECG findings. But there's this borderline area where we decided if you had it in isolation, you move to the green box. If you had it with 2 or more of these, with one of these red ones, you move to the red box. How did this actually compare? The most important thing with this study is we compared it with athletes that had pathology. So we compared it to 103 people in a cardiomyopathy clinic, and we found this, that actually the new criteria was able to lower in whites, blacks, down to 11%, but it still remains sensitive and specific to identifying cardiac pathology. How did this apply to our Arabic athletes? Well, here is the crux of the argument. With this new refined criteria developed in Aspetar, we were able to identify, we've taken 22% of the abnormal ECG criteria from the European Society. About 3 years ago, we had the Seattle with the new refined criteria. We are now showing that overall, we have about 5% of athletes with an abnormal ECG compared to 22 in 2010. In black athletes, it's now 10%. In Arabs, we're down to the lowest point of 3.6. This is the lowest Arabic figure we've ever seen. And in our white athletes, we've gone from 18 to 2%. So again, we are cost-saving the GCC community. We now know that these athletes who have these ECG patterns actually aren't in the red box, are on the green box and saving considerable time. But the most important point, the new refined criteria is 100% sensitive, and our specificity has improved from 76 to 94%. So I go against the Americans in saying that ECG is not cost-effective. I find that ECG peculiarities in athletes are extremely common, and if interpreted correctly, you can have a low false positive rate. And it's important because sports medicine physicians out here in the community are working with athletes, and when you have an athlete who has a €100,000 contract a month, it's important to get the ECG correct in the interpretation, and it's essential to take a look at the athlete's ethnicity first when you do your ECG interpretation, because different rules apply for different ethnicities. Thank you.